Good morning. I'm Dr. Fadi, anesthesia specialist, and we are going to talk about the fluid management strategies and their interaction with mechanical ventilation. Uh, Optimizing tissue perfusion and oxygen delivery while preventing fluid overload is a challenge in a critically ill patient. Restrictive fluid management can be associated with peripheral hyperperfusion and distal organ damage. Liberal fluid management could increase mortality because it may lead to endothelial cell damage, lung and peripheral tissue edema, increased intra-abdominal pressure, and gastrointestinal and renal dysfunction. Variation in pleural and transpulmonary pressure caused by assisted or controlled mechanical ventilation have been shown to affect the cardiac preload and afterload, as well as capillary transvascular filtration pressure. Mismatch between fluid and ventilatory strategies can worsen ventilator-induced lung injury as well as reduce cardiac output and tissue perfusion. Physiological rationale, heart-lung interaction, and distal organ damage. Because of its location, the heart is inevitably subjected to the mechanical forces of the lung, namely pleural pressure and transpulmonary pressure. These forces can have an impact on at least two factors regulating cardiac output: venous return and heart's ability to deal with the preload during the systolic phase. During spontaneous breathing, pleural pressure is negative during the expiratory phase and even more negative during inspiration, favoring system venous return to normal or hypervolemia. During positive pressure ventilation, the increase in intrathoracic pressure increase right arterial pressure, reducing systemic venous return. And also during positive pressure ventilation, when the pulmonary pressure is positive, the left ventricle in turn has its afterload reduced by a lower transmural pressure. Transmural pressure is the difference between the two sides of the wall of the ventricle. Ventricular transmural pressure tends to decrease because it is the difference between ventricle and pleural pressure. Transiently increased preload by a higher alveolar pressure that squeeze blood toward the left ventricle. However, over time, the transmural pressure may recover due to increased stress volume or vessel tone, which in turn can increase the mean systemic filling pressure, favoring venous return. Under protective mechanical ventilation, about 70% plus minus 27% of airway pressure is transmitted to juxtatic cardiac pleural. 37% plus minus 17% to the pericardium, and 43% plus minus 11% to the vena cava. These numbers, these numbers can be even higher when the chest wall compliance is reduced. Organ perfusion pressure is determined by the difference between inflow and outflow pressure. Therefore, a higher intrathoracic pressure during positive pressure ventilation may potentially compromise organ perfusion, ultimately leading to organ damage. Because the right ventricle has less contractical reserve than the left ventricle, intrathoracic pressure and afterload swing during the respiratory cycle have a greater effect on the former than the latter. This concept becomes especially important in ARDS, where hypoxic valve constriction can increase right ventricle afterload, which may lead to right cardiac failure. Pulmonary transvascular filtration pressure is defined as a difference between vascular hydrostatic pressure, pH, and pulmonary pressure. Spontaneous breathing and assisted ventilation, such as a pressure support ventilation, that's patient doing effort to take his own breath. A more negative inspiratory pulmonary pressure may increase transvascular filtration pressure. In the presence of extremely negative pulmonary pressure due to the intense inspiratory effort against obstructed airway, a sudden increase in pulmonary transvascular filtration pressure and lung edema may occur. The association between negative pulmonary pressure resulting from spontaneous breathing or assisted ventilation and hypervolemia that may be caused by liberal fluids, increase hydrostatic pressure thus increasing the risk of edema, which can be even worse in the presence of increased vascular permeability. The mechanical ventilation mode, whether spontaneous or controlled, can change intrathoracic pressure and may lead to changes in the hemodynamics. So we'll try to talk about now what is liberal and restrictive fluid management, search for an objective definition. Restrictive versus liberal fluid management have been compared in various settings, albeit not clearly defined due to the different terminologies adopted in the clinical studies. Conservative and restrictive are used without any clearly defined pattern regarding fluid rate. There is an overall lack of consensus on this. For example, a restrictive approach like 6 ml per kg per hour has been compared with conservative approach 12 ml per kg per hour. Higher fluid rates are frequently named liberal, and older clinical studies use liberal such as standard, high volume, and even aggressive. Experimental and clinical studies have so far used the term liberal over a remarkably wide range from 1.2 to 12 times the fluid rate referred to as restrictive. Impact of restrictive versus liberal fluid management on lung and distal organ damage. Recent surgical and intensive care guidelines such enhanced recovery from anesthesia and surgery, ERES, and UK guidelines for management of ARDS support restrictive fluid therapies. Increased central venous and capillary hydrostatic pressure may reduce organ perfusion pressure and facilitate lung edema. In acute lung injury, increased capillary hydrostatic pressure caused by liberal fluid was shown to promote a prevascular lung edema than a restrictive approach. Higher fluid rate could even increase the risk of developing ARDS after surgery. Thus, the main consequences of liberal fluid may be lung edema, reduced oxygen delivery, and distal oxygen damage. But on the other hand, an excessively restrictive approach can lead to renal hypoperfusion and further functional impairment. There is not enough evidence to recommend a restrictive fluid in the first 24 hours of resuscitation in patients with signs of hypoperfusion and volume depletion. Studies showed no difference in 90-day mortality in patients in ICU when comparing slower versus faster crystalloid effusion rate. In major abdominal surgery, restrictive fluid resulted in a higher acute kidney injury, uh, need for renal replacement therapy, and surgical site infection rate than a liberal approach. It's 80.6% versus 5%, 16.5% versus 13.6%, and 0.9 to 0.3% respectively. Even in specific syndromes such as ARDS, it seems that distinct phenotypes, hyper or hypoinflammatory, may respond differently to restrictive or liberal approaches. A patient with trauma, aspiration, or pneumonia had lower 90-day mortality under restrictive fluid management, whereas patients with sepsis as a primary risk factor and a lower central venous pressure had lower mortality under a liberal fluid management. Thus, fluid therapy should be individualized according to the patient's specific needs. Enhanced recovery of anesthesia surgery guidelines strongly recommended avoiding excessively restrictive or liberal fluid regime during lung surgery. Also supports goal-directed fluid therapy with dynamic monitoring over a liberal fluid management for renal transplantation. Over the last decades, attempts to improve outcomes by fluid balance have ranged from dehydration and negative fluid balance to normovolemia and even moderate hypervolemia as primary therapeutic goals. The 2018 European Society of Intensive Care Medicine consensus statement on fluid therapy in neurointensive care suggested targeting normovolemia during fluid replacement in patients with a brain injury. Now, impact of assisted versus controlled mechanical ventilation on lung and distal organ damage. Some studies have suggested that assisted spontaneous breathing modes such as pressure support ventilation could be associated with a reduction in ventilatory induced lung injury and lengths of stay in ICU and an increase in ventilator free days. Although assisted ventilation can prevent the harmful effect controlled mechanical ventilation, intense inspiratory efforts during assisted ventilation can dramatically change the intrathoracic pressure. This can lead to increased lung perfusion and transvascular filtration pressure and facilitate alveolar edema. Increased inspiratory efforts may lead to a patient's self-inflicted lung injury and negative pressure edema. This situation could be even worse in lungs with endothelial injury. A recent study hypothesized the intrapulmonary desynchrony, example pendulift, defined as a percentage of tidal volume that moves during inspiration from non-dependent to the dependent lung region, could be a leading mechanism for ventilatory-induced lung injury and patient self-inflicted lung injury. Regional pendulift during a pipe up may reflect local swing in pulmonary pressure during spontaneous breathing and be associated with an increase in specific inflammatory biomarkers in patients with ARDS. On the other hand, muscle paralysis and controlled ventilations were shown to be safer than spontaneous breathing in severe acute lung injury in an animal model. Protective controlled ventilation. What is protective controlled ventilation? The low tidal volume and moderate to high PEEP after recruitment maneuver is associated with a lower incidence of acute kidney injury and reduced pulmonary complication and mortality. But also higher PEEP and peak inspiratory pressure may be associated with a distal organ damage as long as hemodynamics are altered and vasopressin secretion is increased. Also, a high PEEP may produce a masking effect on the PaO2 to FiO2 ratio due to changes in hemodynamics, namely a reduction in cardiac output and proportional reduction in venous admixture. Now, interaction between mechanical ventilation and the fluid management. In 1947, research first showed a reduction in renal blood flow, uh, glomerular filtration rate, and urine output during positive airway pressure. Since then, only a few studies have assessed the interaction between fluid and ventilatory strategies. Here we discuss the evidence comparing lung and organ damage under assisted or controlled ventilation in restrictive and liberal fluid management. Pressure support ventilation is a frequently used mode of assist ventilation in patients who are breathing spontaneously. Intense inspiratory effort during assist ventilation could lead to a hemodynamic impairment, higher transpulmonary pressure, increased lung perfusion, and likely patient self-inflicted lung injury. Judicious adjustment of delta pressure. Delta pressure is the pressure that will be above the PEEP during a pressure support ventilation or assist mode and a higher PEEP levels can help patient self-inflicted lung injury and possibly protect patient during assisted ventilation, mainly with liberal fluid management. The increased transvascular pressure caused by increased inspiratory efforts and liberal fluid might cause vascular shear stress, ongoing endothelial damage, and alveolar edema in patients with high capillary permeability as observed in sepsis and ARDS. The effect of controlled ventilation on cardiac output and tissue perfusion partially depended on tidal volume. In this context, both pressure control ventilation and volume control ventilation with the same tidal volume resulted in comparable cardiac output during mechanical ventilation. But we see that during pressure control ventilation may result in higher cardiac output when lower tidal volume are used. The reduction in cardiac output observed in volume control ventilation partially explains the negative impact of positive pressure ventilation on renal function. However, other mechanisms may play a role in the development of kidney injury, including redistribution of intrarenal blood flow, hyperactivation of the sympathetic nervous system, and the action of inflammatory mediators. In attempt to improve cardiac output, liberal fluid strategy may be advised. First, to improve cardiac output, the patient must be fluid responsive. If cardiac output response is negligible, the fluid should be stopped. Second, stretched alveolar epithelial cell can have disrupted tight junctions. In this case, a high hydrostatic pressure could worsen lung edema. Research have shown that superior vena cava transmural pressure decreased during inspiration in volume controlled ventilation, whereas right atrium transmural pressure did not. This reduction of transmural pressure in the intrathoracic vessels could be protective with a lateral fluid management because it would reduce transvascular filtration and formation of edema. Also, no clinical study have investigated this interaction of chloride-rich fluid can promote renal vasoconstriction, which could be even worse in the presence of positive pressure ventilation. The combination of liberal fluid and pressure support ventilation increase alveolar diffuse damage and MMP9 gene expression and decreased specific biomarkers associated with epithelial integrity. It has been shown that pressure support ventilation in combination with restrictive fluid strategy resulted in less lung epithelial damage in a model of acute lung injury. One likely explanation is that damage to tie junctions, which was identified by a decrease in occludin expression, was observed in animals during pressure support ventilation, combined only with the liberal fluid strategy but not with the restrictive fluid approach. Also, no difference in kidney morphology were observed. NGAL neutrophil gelatinase associated lipocalin expression during pressure support ventilation was lower with a liberal fluid approach compared with a restrictive fluid approach. Also, the choice of PEEP levels. It has been shown in clinical studies that a high PEEP level can decrease kidney function despite the fluid strategy because it can increase peak inspiratory pressure. The combination of high PEEP and liberal fluid worsened lung injury in a marine model of ARDS. In addition, an abrupt decrease in PEEP has been shown to increase club cell 16 protein, an alveolar epithelial cell damage marker, in experimental model of ARDS. When combined with the liberal fluid management, it worsened diffuse alveolar damage and increased the level of inflammatory and endothelial cell damage biomarkers. So, clinical implication. Whenever restrictive or liberal fluid are strongly recommended, caution should be taken when choosing the ventilatory strategy, especially in the early phase of resuscitation, when large amounts of fluid are warranted. Assisted ventilation and intense inspiratory effort may cause higher transvascular filtration pressure, vascular edema, and epithelial cell damage, especially with concurrent lung and endothelial damage. Experimental data show that despite protective ventilation, high and rapid intravenous fluid boluses can be associated with worse lung injury and respiratory function. In this setting, careful titration of fluid therapy or obtaining for controlled ventilation is probably beneficial. In contrast, wherever a patient receives a combined strategy with restrictive fluid and controlled mechanical ventilation, distal organ damage should be closely monitored, especially when high PEEP is used or when decreased lung compliance leads to high peak inspiratory pressure. Ventilatory setting should also be carefully titrated because the association between higher PEEPs and liberal fluids may be worsen lung injury, and the association between higher PEEPs and restrictive fluid may aggravate distal organ damage. So, our conclusion, the understanding of physiological heart-lung interaction is fundamental to optimize the fluid strategies and mechanical ventilation setting. Accepted definition of restrictive and liberal fluid strategy do not exist. Both restrictive and liberal fluid strategy may lead to hyperperfusion and edema of distal organ respectively. Assisted ventilation may cause self-inflicted lung injury associated with liberal fluid strategy, while controlled ventilation may impair hemodynamics and thus distal organ damage with restrictive fluid strategy, especially when high PEEP levels are used. And gradual transition of ventilatory patterns is suggested to promote lung protection due to the impact of on vascular compartment. Optimizing of the type of mechanical ventilation setting should consider careful titration of fluid strategy in critically ill patients. And thank you.